Hey everyone and welcome. Today we're going to be covering a couple of different things. First is going to be chapter 8 on intake interviewing and report writing. And finally, we're going to be looking at number 9, the mental status evaluation. Something to think about is that with both intake interviewing and report writing, as well as the MSE, these are things that we're going to be reviewing more in depth in person when we actually have the documents and we start reviewing them together. So, one things that we've talked about in the past is that treatment begins with an intake interview. That's what we've been talking about for the last several chapters. You are going to have to simultaneously and efficiently gather information about our clients while establishing and maintaining rapport. There's a fine balance to doing this, and we're going to be practicing this skill more as we go on with the class. So this chapter is going to take you through a metaphorical walk in what the intake interview process actually looks like. So what is the intake interview? This is the first meeting between a client and the therapist. It's often going to be an initial assessment that involves identifying problems or even diagnosing, defining what the goals are, and setting up what treatment planning is going to look like. The intake is going to blend right into the treatment process. So you have the client interview, then you have the intake interview, and then you go right into what it is going to look like in order to do therapy. So some questions for you to think about is, have you ever written or read an intake report? And what do you think are things that we're going to need to know about in this approach? What are your assumptions about this process? Because whatever they are, you're probably going to want to throw them out the window. There are 3 overarching objectives when we talk about the intake interview. First, you're going to identify, evaluate, and explore what the major complaints and goals are of our clients. And remember, the problem that they're going to be presented with is not going to be the overarching problem. The overarching problem is going to take time to kind of dive into. So you can start exploring this in this session, or you'll discover it later on as you get to know each other. You're going to obtain information related to the interpersonal story of our clients. Not only that story via the thoughts, but also their behaviors, as well as a psychosocial history. And finally, you're going to evaluate their current life situation and functioning. Because again, as our clients are coming to see us, they're often at a very low place in life, and they typically are not going to be at their best, which means that there's going to be areas of deficit in their life that they're going to need to have worked through. So when we identify, evaluate, and explore the problems and goals, you're going to have to ask some probing questions. And really, you definitely want to ask the question and get it answered as to, why are they here? Why are they here seeking therapy? Why now? Some of the problems are often going to be intrinsically linked to their goals, even if they can't see their goals. So a way for us to be able to analyze and assess this is going to be important for us, as well as continuing to build the rapport that we have with our clients. The more we can build a stronger relationship with them, the more they're going to be willing to talk to us. We also want to reframe our client problems into goals, because that helps to facilitate hope and positive goal setting processes with our clients later on. So something to think about is, and when you ask a question to our clients like, so what brings you here today? It could be, again, internally focused or externally focused. If we can take what they're saying and try to shift it into not only identifying this problem, but also starting to think about goals, it helps to also shift our clients' mindsets, which is going to be huge. And again, the presenting problem is only a presenting problem because this is what the client is now seeing. There have probably been other things that have occurred prior to them seeing this that they might have overlooked or avoided. So these are things that we're going to find out not only in this session, even if it's on a small scale, but as we go through therapy treatment with them, we'll find out more about their behaviors, their insights, or even lack thereof. When we think about problem and goal assessments, we are going to essentially be doing the following. We're going to be prioritizing and selecting client problems and goals. We're going to analyze those problems and goals. We're going to use different questionnaires and rating scales, much like the assessments that all of you have worked on, in order to help us find out where they're functioning at now and where they want to go. And then also we're going to look at the behavioral ABCs. So again, most clients are going to come to us at one of their lowest points. For some of them, they're going to have a variety of complaints and maybe even some vague symptoms. So we need to identify what their problems are. They need to be analyzed, and we need to essentially put them into order, because some problems may take additional time to work through, whereas other problems are going to be more immediate for them that we need to address today. And those other problems later can be addressed as we solve either the most important problem that's plaguing them at this time, or the time-sensitive problems, or the skills that they learn from dealing with that time-sensitive problem may actually help them with those longer-term problems. But as we prioritize these issues, they should be collaborative, and we need to follow the client's lead. So if the client comes to us and says that they're fighting a lot with their wife, they're fighting a lot with their boss, and they're in jeopardy of losing their home, well, something we might want to try to work on first would be, the threat of them losing their home, because if they have instability in their housing, that's going to probably further impact their job and or their relationship with their spouse. So even if our client doesn't see that as the primary goal, skills that we would use to work with the relationship with the wife and the relationship with the boss may also be helpful for them with prioritizing for them potentially losing their house. We're going to have to do some extensive questioning. So some of the questions you might want to ask would be, when did the problem or the symptom first occur? Where were you and what was exactly happening when you first noticed the problem? Have you tried to cope or eliminate this problem? What have you done that was successful? What else has been helpful? So when we are analyzing our client problems, we're probably going to want to look at a couple of different things. So the different question categories that we're going to look at are going to include the antecedent or triggering questions, questions focusing on the problem, coping questions, and questions that stimulate client reflections on the problem. So when we are thinking about these different question types, and I apologize, I thought I had outlined them a little bit more. When we are thinking about these types of questions, first, when we talk about triggering questions are essentially to get them to not to be triggered emotionally, but to be triggered cognitively. Get them to start thinking about what exactly is happening, the who, when, where, what, why, and hows of the problems or the symptoms that they're talking about. We may also have to question or use a series of questions that focus on the problem experience. So much like the triggering questions of what caused this problem or symptoms, or when did they first identify this, but how has the problem impacted their life? We're also going to be asking coping questions. What are you doing to take care of yourself? What has worked for you? What hasn't worked for you? Essentially looking at what treatments are in their own personal toolkit. And finally, questions that stimulate client reflections on the problem. We're going to have to ask them questions along the lines of, and when you experience these symptoms, how does your body react to it? How do you react to it? If you're having a problem with your wife, if that's one of the chief complaints, what happens when your wife does something that upsets you? Is this something that you've been doing for a while? Is this, how maybe you would want to be spoken to? You can start asking them to get them to think about, like, okay, is the way that I'm handling the situation okay? Is the way that I'm handling the situation a problem in potentially other areas of my life? Is how I'm handling the situation the way that I would want to handle the situation, or how I'd want someone to react to me? You can get them to start thinking about these things. When you talk about stimulating the reflections on the problem, you want to try to get them to think about them and their reflection on the problem. It would probably be best, unless you have, great rapport with the client. Like an example of great rapport would be that this is a client that you've seen in the past and they're coming back to see you. If you have good rapport with them, you can ask them, Okay, so when you react this way to your wife, is that how you would want your wife to treat you? If you don't have that client relationship yet, you may want to refrain from those types of questions very early on because it could cause reactivity and it may lead the client to become defensive. In that case, when you're looking at client reflections on the problem, it may be asking them questions about how does this problem or these symptoms impact them personally? How does it impact their relationships with people? How does it impact them at their job or at school? Does it impact them in any other areas of life that you haven't addressed? Has this problem been going on for a long time, or what's the period of time that this problem or these symptoms have been identified? We also want to use questionnaires and rating scales. So some of these are going to be questionnaires that you as a class are going to be presenting on. So we'll be learning more about them. But when you think about the questionnaires that are available, essentially it's a way, the questionnaires are a way for you essentially to find out where they are at that point in time. They could be thought of as sort of like a written interview. They are often going to be, a type of research and gathering information that can figure out where they are at this point in time. And those questionnaires can then be used later as needed to see how they have shown improvements or if they have regressed. When you talk about a collaborative and therapeutic assessment, these are going to be things that are essentially very similar to questionnaires, but they are going to be slightly different. It's just the best way I can describe it right now. So in a therapeutic assessment is essentially some type of psychological assessment that aims at helping people to gain insight into problems in their lives. And when you talk about therapeutic assessments, it's different than a questionnaire because the questionnaire looks at the basic functioning of how a person is at that point in time, whereas the assessment, it goes in a lot deeper. So typically with therapeutic assessments, we follow Stephen Finn's model. We want to make sure that the clinician or you are collaborating with your clients in doing this. You don't make the decision to do it. You talk to them about it and ask them essentially for their buy-in. The data is then contextualized in a way that helps you to understand where they're at in their understanding of the problem, and also then providing psychoeducation to our clients to help them find out where they're at in their functioning. The assessment is part of an intervention, and part of that intervention is to raise awareness and to further help our clients to understand the potential severity of their situation. It can be used to help our clients understand just how much they are or are not functioning in the world around them. And it also can provide insight to our clients as far as what additional things are that may be plaguing them, other symptoms or potential other problems, which can then raise awareness to them. And then those can be things that can also be addressed in therapy. When we think about this, we need to make sure that our clients are described and not labeled. So when we are giving them an assessment that looks at depression, we need to make sure that we are describing our client in the way of symptoms of depression, not that they are depressed. That label, if we look at a sociological frame and thinking about labeling theory, when people have a label put on them, they tend to internalize and then own that label and act out accordingly. So we want to make sure that we describe to our clients based in an educational perspective of symptoms, not as you are depressed or that you are this concern. And finally, we need to respect the complexity of our clients, that they may be functioning in some areas of their life better than others. And that these issues may seem simple for us to be like, well, why don't you just do this? And then you won't have any more problems. But that our clients may be blocked by something and something that we may not recognize yet. So to be as respectful and kind as we can to our clients and understanding that this process is just that, it is a process. Then we talk about the behavioral ABCs. When we talk about the behavioral ABCs, we are talking about how we are essentially looking at the way of observing behavior. So this typically is going to involve our direct observation and recording of some situational factors that we see in session, and also for our clients to observe and record in their life outside of the therapeutic session, which can be used to identify and then work on problematic behaviors, and even some form of thoughts that may lead into behaviors. So the ABCs themselves, the first is going to be the behavioral antecedent. This is the event or the action or the circumstance that occurs immediately before a behavior. The B is the behavior or the problem itself. And this is where you're going to detail the behavior. And finally, the C of the ABCs is consequences. These are the actions or responses that immediately follow the behavior. So you're essentially looking at what led to the problematic behavior, the behavior itself, and then what was the reaction to the behavior. In doing these things, and in finding out these symptoms that are leading to the problem, it not only helps us to set ourselves up for treatment for what our goals and our solutions are going to be, but typically when we think about the symptomology, it's going to occur in the context of individual clients who are coming from different family systems, neighborhoods, cultures, and hold multiple individual and collective identities. So when we're getting this information, it's really important to get it from our individual client, but also to get it from other people as well, because our client has a very subjective focus point. If we look outside of our clients, we may be able to find that there are other people who can help us. Their primary care physician, family members, their current partner, any friends, any other doctors that they have seen. They can help to expand on our understanding of not only the client, but also their behaviors and how these behaviors may have shifted. They may also see something that our client may be blocked by seeing. So they may be able to see when the problem started, whereas our client may not be able to see that. Or people may be able to report how the problem has exacerbated and impacted multiple areas of their life, whereas our client may be avoiding seeing that or unable to see it at that time. So if we are able to talk to people that may be able to help us expand the knowledge base beyond our client, now remember, in doing that, let me take a step back. If we are able to talk to a primary care physician and previous people that they have spoken with, other therapists, psychiatrists, gynecologists, urologists, etc., if they've ever been in an inpatient or outpatient setting, and then loved ones. We must get verbal and written consent from the client in order to do so. We cannot pressure our clients in order to be able to give consent to have these conversations. But if we are able to get them and get that personal history, that will only enrich the information that you as a therapist will be able to provide to our clients, and also will help you fill in any gaps in their personal information. So when we shift to the personal or psychosocial history, something that we need to help us is, kind of figuring out why now. Why now is going to be a huge thing. It gets us to think about why are the clients coming to see us. It'll give us insight into how much our client wants to work with us and what they are willing to do in the therapy session or in a therapeutic setting. And also gives the client an opportunity to start reflecting on, what has stopped them in the past from being able to come gather support. And again, it also gives us sort of that starting point of, when did these events begin? When did they begin versus when they came to counseling? If it was a short period of time or a long period of time, it just means that things may have happened in between when the symptoms and the problems started to where they are today that may compound why they're feeling the way they're feeling or reacting the way that they're reacting. We typically can do this in a non-directive way or in a directive way. A non-directive way would be where you are giving them essentially the floor. where you give them an open rein. So, where would you like to start? Very open-ended. It gives them an opportunity if they want to go to when the problem started, and then work forward where they are today and work back. It's very non-directive in that. More directive historical leads are where you're going to be asking specific questions about people in their life, issues that are, previous issues, what their family system is like, even some of their earliest memories of when similar problems had begun to take place. If you run into some pretty sensitive topics, so like child abuse or other emotional topics, you definitely want to be supportive and empathetic, because for our client, it could be one of the first times they're disclosing these things. You can also listen for ways that your client was strong during those difficult times and be able to reflect that back to them, which is helpful for them in understanding that they do have skills within themselves to help themselves. You may also do things like, depending on the client, you may have to provide them with some techniques in case they have or they report having a history of dysregulation that can lead them to self-injurious behaviors or suicidal ideations. You may have to create a crisis plan with them and then provide them things that can help them between sessions, like progressive muscle relaxation techniques or meditation techniques, or even apps that can help them with meditation, helping them to dive into what their therapeutic toolkit would look like. What do they like to smell or listen to or touch or see whenever they feel like they're becoming dysregulated? You also have to evaluate interpersonal behavior. So we're going to have 5 data sources that we can get this from. And we've talked about the client self-report. There's also our observations during the interview, any assessments that you use, such as the ones that you'll be presenting on, any past psychological records or reports, and information from collateral informants. So if they were able to, if they provided consent to have their significant other to talk, or a parent or a sibling or a friend, those are all part of collateral informants. When we're evaluating interpersonal behavior, the clients have a couple of things that we need to think about. They have a pattern of behavior, sort of like an internal working model that guide these behaviors. And as functional or dysfunctional as they may appear, these are the patterns that they have. Cognitive therapists call these client schema or schemata. And that essentially leads our clients to typically react in a way that can be problematic. Alderian therapists will call these lifestyle or style of life. Psychoanalytic therapists will call these core conflictual relational themes, but typically we're going to look at them as schemata. So if someone approaches them negatively, they may become reactive. That's part of their schemata. If they receive news that is supposed to be constructive in nature and they internalize it and become very sad to the point of experiencing depressive symptoms, we can look at that as another form of schemata. Typically, our clients are going to have multiple schemata or multiple schemas that dictate how they will react in similar situations. When we look at the assessment of current functioning, we're going to see that, we're going to talk about that now. We're also going to talk about that in the mental status evaluation. But when we look at current functioning, we want to shift back to the present and ask specific questions. We want to challenge our clients to move from the past to the present, because that's how we're going to find out how they are now. It may be easier for them to talk about the past than it is to talk about the present. So gently challenging and guiding them back to the present may present some resistance from our clients, but it'll give us an understanding of, okay, if you're not willing to talk about what's happening presently, that tells us something about what may be going on. If you are very focused on the past, that also gives us something to tell us that there might be something that is going on. The way that they are able to go from past to present, the way that they are resistant to doing that, those are all little seeds for you as a therapist to start putting together in the treatment plan. And there are going to be many strategies and techniques to help clients regain that emotional control of going from past to present. And you'll be learning them throughout your time at Rowan. So some ways you can help clients regain emotional control is to focus on the present or the immediate future. You can ask the client what helps them to soothe themselves. We can shift to a more positive issue or even a more neutral issue. We can give compliments. I'd avoid suggestions, but you could offer a lot of compliments like, wow, in that situation, it really sounded like you were strong when you did this. You can acknowledge the negative while reviewing the positives, and you can engage in some type of centering or grounding activity. No matter what we do, we have to review goals and monitor change. Many therapists will pose these future-oriented questions towards the end of the intake so that it gets our clients to think about what it is they want to do moving forward. Now that they're here, now that they've done this session, where do they want to go next? So you can ask questions like, if therapy is successful, what will change? What will let you know that there's a change? How do you see yourself changing in the next several years? What personal or career goals are you striving towards? There are some factors that may impact the intake interview. First are the client registration forms. So we have to make sure that our client signs a lot of documentation. Those documents are going to be super important. They protect you, they protect the client, they protect the agency, and they'll also allow you to bill. The institutional setting of where you're at may be a turnoff for some of our clients. It may dysregulate them. It may bring them to think of a previous memory that is challenging to them. It may also not be as warm and friendly as you'd like it to be, which can cause the client to struggle to open up to you as quickly. Depending on your theoretical orientation, what you employ may not mesh with the client. And that's okay. If it doesn't, then you want to make sure that you make proper referrals. Finally, professional background and affiliation. It's super important that if you are an intern that you disclose that to your client and you let them know, I just want to let you know that I'm a intern at Rowan University or wherever graduate school you go to, but that I'm an intern at this school. This is my supervisor's information. This is my supervisor's license number. You know, that the work that I'm doing is going to be helping me to work towards licensed professional counselor status or psychologist, but we have to be very open with them. If this is something that your client is not comfortable with, then it's okay for them to express that and then to work with your supervisor to find them someone that's more appropriate. When we think about the intake interviewing, we need to be brief. We're going to rely on registration forms and questionnaires to gather a lot of this information. And this is going to be very directive from you because you're going to be using more questions and allocate a lot less time for client expression. It's about dotting your I's, crossing your T's, getting the historical information. And in order for this to go successfully, you typically have about a 60-minute time frame. In order for this to go well, you probably want to reduce time spent on your psychosocial history and interpersonal behavior because these are things that you can gather in future sessions, especially if our client has a very long history of previous treatments and has previous experience in the mental health field. So when you think about the intake report, I'm going to be showing you examples of this in class. You need to remember your audience. You need to remember the ethics of report writing. You need to choose the structure and content of your report and write clearly and concisely. So remembering your audience is going to include a couple of things. Listed on the screen is your client, supervisor, agency, attorneys, the client's former spouse and insurance companies, professional colleagues, ethics boards of the professional association that you are affiliated with, whether that's the APA, the ACA, or the NASW, as well as your local, state, and professional ethics boards. So you want to consider how you're going to handle this information and use non-discriminatory language and be prepared to share the intake reports with clients. You don't want to write something in there, especially if it's your observation about the client, that may impact the therapeutic relationship. We need to be neutral with what we write. We need to be objective, not subjective, but we need to be objective using as much of the client language as possible. And we need to be careful in putting in too many details. We need to be detailed enough, but not too detailed that it may harm them. So you can choose the structure and the content of your report. So identify information and the reason for referral that's going to be in this initial client intake note. Any observations, such as the MSE, that's going to be used in all of your notes moving forward. You want to look at a history of the presenting problem or illness, past personal and family treatment history, including substance use disorders and mental health issues, any relevant medical history, such as diabetes, cardiovascular related issues, adrenal issues, endocrine system issues, cancers, etc. Not only for themselves, but also for their family. Any developmental history that the client knows of. Social and family history, that's going to be huge. That's going to help, again, fit together those missing pieces of the puzzle. You want to include any formal assessment data from the ones that you'll be presenting on in class if you choose to use them, or similar ones. Any diagnostic impressions that you are getting based on symptomology that they've discussed. So if they're talking about extreme sadness, lethargy, sleeping a lot, having issues getting out of bed, losing interest in things that they once enjoyed, if they talked about having in the past but not presently suicidal ideations, this may be symptoms of depression. So part of the diagnostic impressions is going to be reflecting back what your client said their symptoms were and using the DSM-5 to support any diagnoses that you come up with. The last thing is going to be a case formulation and treatment plan. This is going to be, the case formulation is a very condensed background information about your client, typically in a one-page synopsis. And the treatment plan is going to be, this is what we, in the next 90 days, 120 days, 180 days, whatever your goal is set out for yourself and your agency, as well as the client. These are the goals and the steps that we want to achieve over this time period, and that we will reevaluate in 90 days, 120 days, 180 days. You want to write clearly and concisely. Many of the reports are done electronically, so you'll have an opportunity to type them out. You want to write the report as soon as possible whenever you have a client coming in for their after their initial intake. You want to write a draft without worrying about perfect wording or style, and typically your agency will have an outline for you to follow. You want to get clear information from your supervisor or employer about the intake report writing experiences. In many cases, if you are being supervised, you will write this out based on a format that they provide to you, and then you will submit that to your supervisor for them to review, and then they will offer you feedback. You can also check out some sample reports online. I actually include one in the packet of information for you. And the more that you write these reports, the easier that they will in fact become. So your first few may have bumps in them. They may not be your best writing, but as you get more proficient with this, you will find that it becomes easier and you will know to look out for certain things. So some do's and don'ts of intake interviews with diverse clients. Don't do an activity because you don't know if that activity could be offensive to the client. You want to discuss the list of do's and don'ts in the text. They actually have a pretty good outline there for you. You want to use your own expertise to modify that list. And also, something that you can do and that we're going to talk about together is that we can report it back to the class of different do's and don'ts of intakes. And we're actually going to be talking about that at our next class as we're reviewing some of the documentation that our clients are going to be signing.